All right, let's just dive right into this explainer. Today, we're building a clinical toolkit to crack one of the most common medical mysteries you are ever going to face. We are mastering the musculoskeletal assessment. It's really about taking this incredibly complex system and breaking it down into a highly effective logical diagnostic framework.
You know what's wild? A staggering 20 to 25% of a general practitioner's entire workload, it's purely musculoskeletal problems. Think about that. That means literally 1 in 4 patients walking through your clinic doors is looking for answers about their joints, muscles, or tendons. It's an absolutely massive chunk of daily clinical practice.
And the stakes here, they are huge. MSK disorders are the primary driver behind a whopping 60% of all severe physical disabilities. We aren't just talking about a few minor aches and pains here. We're talking about a person's fundamental ability to just live their life. Getting this assessment right is absolutely crucial if we want to mitigate this societal burden.
So, to tackle this challenge, here is our game plan. First, the musculoskeletal challenge. Second, taking the patient history. Third, the GALS screening exam. And finally, the REMS examination. We're essentially using a funnel approach for our diagnostic detective work, zooming all the way from initial historical clues down to a rapid screening and finally, a hyper-specific joint exam. Let's get into it.
Starting off with Section 1, taking the patient history and gathering those initial clues. Let's see how we build our initial suspect profile.
So, there are over 200 different types of arthritis and MSK conditions out there. Over 200! To narrow that massive list down fast, you have to consistently hit these 5 key questions. First, is the pain in the joint, the tendon, or the muscle? Second, is it acute or chronic? Third, are we looking at something inflammatory or non-inflammatory? Fourth, what's the specific pattern of the affected areas? And fifth, and this is a big one, what is the actual functional impact on the patient's daily life?
Timing is everything here. Establishing the chronology gives us massive clues. You want to track the evolution of the symptoms. Does the pain peak super suddenly overnight, like in a gout attack? Or has it been hanging around past the 6-week mark? Because crossing that 6-week threshold points us toward a chronic issue like rheumatoid or osteoarthritis. It completely pivots your diagnostic path. Now, let's talk about inflammatory versus non-inflammatory conditions, because the contrast is stark. If your patient's early morning stiffness lasts for hours and actually gets better when they move around, you are definitely hunting an inflammatory culprit. But on the flip side, if the stiffness is really localized, lasts under 30 minutes, and gets way worse when they use the joint, that's a non-inflammatory mechanical issue. It's a huge distinction.
All right, Section 2. The GALS screening exam, our quick scan. Now that we have our historical clues, it's time to step into the physical examination lab. We kick things off with GALS. That stands for gait, arms, legs, and spine. This is a brilliantly elegant, foolproof physical scan. And the best part? It takes maybe 1 or 2 minutes to do. But despite being so fast, it's incredibly sensitive at catching significant musculoskeletal red flags before we even need to dig deeper.
You're just methodically stepping through these 4 areas. You watch how they walk, you assess their arms and grip, you check their legs and knees, and you inspect their spinal mobility. By doing this, you're guaranteeing that no major neuromuscular or joint issues slip through the cracks. It's your essential baseline filter. Picture your patient standing right in front of you in the anatomical position. You're checking for symmetry, muscle bulk, and spinal alignment from both the front and the back. Are the shoulders level? Are the quadriceps symmetrical? Just a visual inspection in this anatomical position is a surprisingly powerful first physical diagnostic tool.
Moving down to the legs, we use a neat little maneuver called the patellar tap. Essentially, this technique forces any excess fluid, which we call an effusion, down behind the kneecap. When you press on it, it creates this distinct physical bounce or tap. It is just a remarkably simple, straightforward mechanical test for joint swelling.
But here's a tricky question. When we assess the spine during the gall screen, how do we actually isolate lumbar flexion without getting fooled by hip mobility? I mean, a patient touching their toes might just have really great flexible hips, right? So how do we know it's actually the spine doing the work?
Well, the solution is totally tactile. If you place 2 fingers directly on the lumbar vertebrae, you can physically feel those vertebrae separate as the patient bends forward and then come right back together as they stand up. This 2-finger technique takes the hip joint entirely out of the equation.
Once you finish your quick scan, you just jot down the findings in a really simple matrix. By just logging normal or abnormal for appearance and movement across the gait, arms, legs, and spine, you instantly map out exactly where the structural abnormalities are hiding. It creates the perfect roadmap for the rest of your consultation.
Which brings us to Section 3, the REMS examination, the deep dive. If your GALS screen flagged a specific problem, this is where we funnel down.
REMS stands for Regional Examination of the Musculoskeletal System. It's a highly detailed assessment designed by a national consensus to standardize how we physically examine a specific group of linked joints. Think of it this way. If GALS is your metal detector, REMS is the magnifying glass you pull out the second it beeps.
And it doesn't matter which joint you're investigating. Elbow, hip, hand, whatever, you're going to relentlessly apply this exact 4-step sequence. Number 1, look at the joint at rest. 2, feel for temperature and swelling. 3, move it through active and passive ranges. And 4, assess its practical function. Look, feel, move, function. For example, during the look phase, when you're examining the hands, you might notice tiny clues like nail pitting. That instantly points you towards psoriatic arthritis. Little visual indicators like that can completely give away the diagnosis before you have even touched a single joint.
Then, we move to the feel stage. Here, your hands are the ultimate diagnostic tools, and you are hunting for the synovitis triad: warmth, swelling, and tenderness. If you find those 3 cardinal signs, you've confirmed active joint inflammation, which immediately guides your treatment plan.
Next up is the move phase. This is where we separate muscle and tendon problems from internal joint problems. We do this by looking at both active motions, like having the patient do the prayer sign, and passive tests that you, the clinician, perform. If a joint moves perfectly fine passively, but the patient can't do it actively, you know the joint structure is probably fine, but the driving muscle or tendon is compromised.
But here is the absolutely crucial takeaway for all of this. Your bedside manner? It isn't just about being polite. Getting the patient to relax is a strict mechanical requirement for an accurate exam. If your patient is tense and guarding their muscles because they are uncomfortable or in pain, you literally will not be able to feel the structural clues you are searching for.
So, armed with this macro to micro toolkit, how are you going to apply the GALS and REMS frameworks in your very next clinical encounter? Can you spot the clues before they become chronic? Keep this funnel strategy in mind, let the history guide your screening, and you'll be well on your way to mastering the musculoskeletal assessment.